is by Arnaldo Lopez Reis. Arnaldo was my fellow, my research fellow in Mississippi. When I first met him, they introduced me to him. He had asked to meet me, and I was like, sure, but I don't have a position for him. Well, I went ahead and got a position for him, and it was one of the best decisions I've ever made. He's been one of the most productive and certainly the most creative fellow I've ever had. So much he did his residency and fellowship with us, and then he went to do critical care at Mayo. Now he's in Orlando at a hospital where he continues to do research and collaborate with us. He's doing some of the Angiotensin 2 work with us, and he's also involved with just looking at AKI and predictors of AKI. He's going to talk to us about predicting AKI using the Furosemide Stress Test as well as biomarkers in the ICU. Welcome, Arnaldo, and thank you.
Thank you so much, Dr. Guncos. Thank you so much for the invitation to the organizer of KidneyCon. So I don't have anything to disclose. So Dr. Ronco and his group has recently shown in this meta-analysis that delayed consultation of the nephrologist in the course of AKI is associated with high mortality. So probably the early involvement of nephrologists may provide substantial advantages in terms of early recognition, prevention of further decline of the renal function, and also providing effective therapy for this condition. And the reason for this probably improvement in mortality is because as a nephrologist, I think that we are trained and better prepared to recognize subclinical AKI and also identify the potential reasons for AKI, such as volume overload, nephrotoxics, and also identify the early disturbances in the electrolyte imbalance or the acid-base disturbances. So we all know the great impact of acute kidney injury and the length of stays, hospital costs, 30 days readmission, and hospital mortality in patients that have acute kidney injury. As you can see in this graph, the severity of each of these variables get worse as the acute kidney injury progresses. For example, if you look at the first panel, the length of stays and the 30-day hospital readmission is greater and very significantly worse in patients with severe AKI or AKI stage 3. And as you can see in this graph, so AKI has a tremendous impact in the inpatient mortality. It can reach up to 10-fold increase. And it has been shown that in post-surgical patients, the incidence of acute kidney injury, it can reach up to 39%. So these are the major risk factors for acute kidney injury in the ICU. And we can divide these risk factors based on patient factors, medication or agents, or procedures associated with higher incidence of acute kidney injury. And I want to highlight the most frequent risk factor that has been shown in multiple studies. And those are mainly the age, advanced age, the presence of diabetes, CKD, hypotension, sepsis, certain medication, especially NSAIDs, and for sure the recent cardiopulmonary surgeries or emergent surgeries. And more recent, the introduction of ECMO has been associated with high incidence of acute kidney injury. So this is a diagram that shows the difficulty that we currently have in the recognition of acute kidney injury. There is usually a normal or physiologic gap between the initial kidney insult and the increase in creatinine. Usually this gap is between 8 to 48 hours. And probably in this period is when the biomarkers can be useful to help us detect the tissue damage, the tissue injury. So this is the current paradigm that we have for acute kidney injury and the knowledge in the gap. And I want to mention three specific points. First is in the clinical recognition. Second is in the established injury. And third is in the evaluation of the progression or recovery of the kidney damage. So if we consider a biomarker that we're going to implement for clinical recognition, these biomarkers should be able to tell us if the damage is actual, the time of onset, the etiology, and if this injury is going to respond to therapy, and if there is a risk for progression. Then in the second graph, that is once the injury is established, if we use a biomarker, this biomarker should be able to tell us if the injury is still progressing, how long is going to last this injury or this damage, and the degree of tissue damage. And of course, if there is any risk for further complications. And lastly, is testing and using biomarkers to determine if the kidney function is going to recover, if it's going to progress to CKD or end-stage renal disease, and if it's going to be associated with systemic complications such as hypertension, or if it's going to be associated with short-term complications, for example, a lung injury or cardiac injury. So implementing a biomarker using this diagram, so we have to use a biomarker, and we have to consider that this biomarker should be elevated very early, so to tell us about the subclinical AKI when we don't have any increase in creatinine. This biomarker should tell us about the etiology and provide prognosis. It should tell us once the injury is established, and it should tell us very early so we can predict how severe is going to get the kidney injury and how high is going to get the creatinine, and if this patient is going to need renal replacement therapy. And lastly is if this biomarker should tell us about the repair, the progression, and the risk for future AKI, and more importantly, it should tell us about the risk for mortality. So this is the current classification of the biomarkers that are used in acute kidney injury, and we have 5 subtypes. Those markers that tell us about the decreased glomerular filtration and are the serum creatinine and the cystatin C. Then we have markers of tubular function. We have the fractional excretion of sodium and the Furosemide Stress Test. Then we have marker of tubular injury, and those are the classic KIM1, NGAL, IL-18, the fatty acid binding protein. Then we have the new marker that has been recently approvated by the FDA, that is the marker of the cell cycle arrest. And we have there the tissue injury, the tissue inhibitor of metalloproteinase, and the insulin growth factor binding protein 7, that in conjunction is called NephroCheck. And then we have other markers of tubular injury that are more related to inflammation, and we have MCP1, IL-6, TNF-alpha, and IL-10. So, but the current diagnosis of AKI relies on 2 markers that are the serum creatinine and the urine output. And we have many issues with these 2 tools, with these 2 biomarkers. First, let's start with the serum creatinine. It is well known and published that 25 to 30% of the production of creatinine is reduced during the course of sepsis or septic shock. It also reduces excretion during high doses of beta-lactams or sulfas. It is reduced in patients with cirrhosis up to 25%. There is a progressive decline in the production of creatinine during the ICU stay. And the production depends greatly on the muscle mass, on the diet intake, and the creatine. So, and there are few days, usually 3 to 4 days, until the rate of production exceeds the excretion, and we see the elevation in creatine. With regards to the urine output, we know that it's very difficult to measure when the patient is not in the ICU. So it requires an accurate measurement for the early detection of acute kidney injury. Usually, severe AKI does not always equate to oliguria, and oliguria does not imply a structural renal injury. So it has been shown that only a urine output of less than 15 cc per hour or less than 0.3 milliliters per kilo per hour for more than 6 hours correlate with renal injury. And oliguria could be the response of normal kidney to hypotension. So these are the main issues that we have with these 2 tools that we normally use and are validated to diagnose acute kidney injury. So over the last few years, with the introduction of the biomarkers, and mainly the NephroCheck that was the most recent biomarker that was approved, we have developed 4 stages for the evaluation and for the diagnosis of acute kidney injury. And in this diagram, I'm showing the 4 possible categories of acute kidney injury. So in the first, in the white panel, we have those patients with low biomarker and stable creatinine or cystatin C. So in that case, they don't have acute kidney injury. Then we have another subgroup that is those with high biomarker, but stable creatinine or stable cystatin C. And we call this subclinical AKI. And then we have those patients with low biomarker, but elevated creatinine or elevated cystatin C. And those are patients usually with hemodynamic AKI. And those patients are usually those patients with decompensated heart failure. And in the last panel in red, we have the classic AKI when the renal injury is established, in which we have high biomarker level associated with elevated creatinine. What happened is that this subgroup of subclinical AKI, it has shown to have high mortality compared to those patients with hemodynamic AKI, and is very close to those patients with established AKI. And the progression for renal replacement therapy is almost equal in these 2 groups. It's for this reason that we have to consider the use of biomarker more active and try to implement in the current care of the patient with acute kidney injury. So this subclinical AKI is considered now acute kidney stress. So it's a pre-injury phase that leads to establish acute kidney injury. And we can divide it in 3 stages. So this is mainly a pathological, histopathological description, and it could be mild, severe, or very severe. In the mild, we have a transient insult that is mild and usually is associated with rapid recovery of the cell function and the replication. In the severe, usually the insult is more severe, is prolonged. There is a cell cycle arrest for energy preservation, and there is no replication of these cells until the insult is removed. And in the very severe, so as I am showing there, the insult is more persistent, is very severe. There is again a cell cycle arrest for energy preservation, but in this case we have evidence of DNA damage. There is no replications, and the chances that these cells progress to a senescent phenotype is very high. And when this happens is when we start seeing apoptosis and fibrosis. So for these cases that are mild, usually there is a rapid recovery with restoration of the replication and probably recovery of the renal function. But in those cases that are severe and very severe is when we have histopathological evidence of apoptosis, autophagy, fibrosis, and necrosis. And probably is in this population or in these cases in which the use of biomarkers is going to help us to predict that these patients are going to progress to more severe AKI. So this is the graph that illustrates the mechanism of action of the 2 biomarkers that I previously mentioned, that is the tissue inhibitor of metalloproteinase number 2 and the insulin growth factor binding protein number 7. So both are cell cycle arrest proteins that can bind specifically to the protein P53 and P27 and are proteins that result in the inhibition or a stop of the replication of the cell in order to protect these cells from necrosis. So this biomarker has been validated and approved by the FDA using in conjunction, and as you can see here, this was the validation study done by Dr. Kashani and his group, and it's showing an area under the curve that is close to 0.8%. In this validation study, they compared to other biomarkers, and as you can see here, is significantly better than urine Engal, plasma Engal, cystatin C, or urine Kim1. They further studied the levels of this biomarker that is called the NephroCheck, And they saw that for levels more than 0.3, we can categorize patient at risk for AKI. And for those patients with level more than 2, we can categorize patient with very high risk for AKI. So just to illustrate how this test is done, is basically an ELISA test. It requires only 100 microliters of urine. The duration of the assay is very simple, 20 to 30 minutes. So the range, and this is something that I would like to highlight, that is very important when we interpret the studies. So the range goes to from 0.3 to 10 nanograms. So as this level gets worse or increase more than 2, so the risk for progression to severe AKI or AKI requiring renal replacement therapy is higher. So, and the approval of the ACA was in conjunction with clinical evaluation in patients who are admitted to the ICU with recent acute cardiovascular or respiratory compromise. And something that I would like to highlight is that this test can predict the development of AKI in the next 12 hours. So this is just to illustrate how the test works and the cutoff. So in patients that are at risk for AKI, the test should be performed within 12 hours of ICU admission or within 12 hours after the surgery, and the cutoff is 0.3. With this cutoff, it has a sensitivity and negative predictive value of 92, 96 respectively. So, and how do we interpret that? So in those patients with more than 0.3, so this patient could develop moderate to severe AKI in the next 12 hours of the testing. And in those patients that has negative tests, the chances to develop acute kidney injury is very low, and it can be considered to repeat the test. However, in those patients that are very high risk, it's recommended to probably repeat the test between 12 and 24 hours after ICU admission or after the surgery. If the patient has a level higher than 2 nanograms per ml, the specificity and the positive predictive value is 90 and 94%. And the interpretation is if this patient has more than 2 in the NephroCheck, the chances to progress to severe AKI or AKI requiring renal replacement therapy in the next 12 hours is very high because it's associated with severe tubular damage. However, in those patients that has level lower than 2 but more than 0.3, it's recommended to repeat the test 1 or 2 more times to evaluate the need or the progression of their renal injury. So the question that we ask is, can the NephroCheck identify acute kidney injury as a sepsis-defining organ failure? So using this biomarker, Dr. Kellum went back and evaluated the SAPPHIRE study group. That it was a study of 723 patients. And he divided those with no infection but not sepsis, or with sepsis. So as you can see here, the NephroCheck, as you can see here in this first graph, the incidence of AKI was much higher in those patients with infection only or in those patients with sepsis. It was significantly higher. But then he evaluated the NephroCheck in this patient with infection only. And he saw that it was significantly higher than those patients with sepsis. And usually these patients with infection only were the patients that progressed to sepsis. So using this biomarker and using the cutoff more than 2 preceded the clinical onset of AKI in 31 hours with an interquartile range of 19 to 40 hours. And as I mentioned in here, 71% of the patients with infection only and result of the NephroCheck more than 2 progressed to AKI 2 or stage 3. So the next question is, does the NephroCheck levels predict AKI-related mortality at 90 days and up to 9 months? So again, Dr. Kellum, using the same group of the SAPPHIRE study, determined that the odds ratio for mortality in those patients with AKI stage 2 or 3 a NephroCheck level higher than significantly higher at 90 days and up to 9 months. And as you can see here, it reached almost 47%. But then he also evaluated the mortality in those patients who had the NephroCheck more than one. And he found the same statistically significant risk for mortality with an odds ratio of 2.44 for those patients with acute kidney injury if he compared with those patients with no AKI. So the next question is, does the use of NephroCheck reduce the need for renal replacement therapy and improve mortality? So this question has been mainly tested in surgical patients. So this was a PREF-AKI trial that it randomized adults that were at high risk for acute kidney injury who underwent cardiac surgery. Most of these patients were patients that went for CABG, and they evaluated the use of NephroCheck in combination with the KDIGO guidelines to prevent AKI. So in one group, in 138 patients, they performed a standard of care evaluating the CVP and mean arterial pressure. And in the other group, they used the KDIGO bundle plus the NephroCheck. So what they found? They found that the risk for all AKI were lower. It was a difference between 71 versus 55%. And then moderate to severe AKI, so AKI stage 2 and AKI stage 3 was also significantly better for the intervention group in which they use the NephroCheck. But very interestingly, they didn't find any difference in the need for renal replacement therapy at 60 or 90 days. There were no difference in all cause of mortality at 60 or 90 days. There were no difference in major adverse kidney events in the same period, and there was no difference in the ICU or hospital length of stay. In another surgical study that was a big pack study, it was again, they tested the use of NephroCheck with the KDIGO bundle versus just a standard of care. In this study, they compared and they randomized 121 patients, but in this case, it was major abdominal surgery. So the outcomes that they evaluated was the incidence of overall acute kidney injury, the severity of acute kidney injury and major adverse kidney events, and the length of stay and the cost. And the take-home point is the overall stages of AKI were not statistically different between the two groups. But if they consider those patients with NephroCheck values between 0.3 and 2, there was some difference in the incidence of AKI. And here I want to stop and make you remember that the NephroCheck range was from 0.3 to 10. So they only consider the specific group in which the NephroCheck was 0.3 to 2, and they found a significant difference for this in the group of severe AKI. There was some difference in the incidence of severe AKI, length of stay in the ICU, and hospital stay were significantly lower in the intervention group. But again, there was no difference in the need for renal replacement therapy, in the inpatient mortality, or in the major adverse kidney events. So based on these two studies, the Cardiothoracic Society and the Society of Surgeons, they implemented the utilization of the NephroCheck to early detect kidney stress and prevent AKI. In their landmark paper and guideline that was published in JAMA Surgery, they recommend that these tests should be done in those patients that has high risk based on the Cleveland Clinic score that was previously validated by Dr. Paganini in 2005. And based on this score, they found that those patients with a score 6 to 8 has a high risk for progressing to AKI, recurrent renal replacement therapy, as the same for those patients who has a score more than 9. So the recommendation is, if using this risk score, and if the patient has a high risk score, implement the use of NephroCheck in post-cardiac or major surgical patients. So the other question that we ask, and we previously talked in the angiotensin 2 lecture, was does the use of NephroCheck in combination with procalcitonin improve the prediction for sepsis, acute kidney injury, and AKI-related mortality? So this was a study that enrolled patients with sepsis versus not sepsis, and they evaluated the use of NephroCheck in combination with procalcitonin. And the secondary endpoint was to evaluate also need for renal replacement therapy, mortality within 7 days. So these were the primary outcome, that was AKI within 48 hours. Secondary outcome was acute kidney disease at 7 days or mortality within 7 days. As you can see here, when you consider both biomarkers, the NephroCheck and the procalcitonin, the odds ratio for this patient with sepsis as well as the patient with no sepsis for AKI within 48 hours is significantly higher. And then if you consider the progression to acute kidney disease or mortality within 7 days, combining these two biomarkers in patients with sepsis is significantly associated with worse outcomes. So does the use of NephroCheck predict the need for renal replacement therapy and ICU mortality in septic patients? So they evaluated this NephroCheck again in patients with acute kidney injury and sepsis, and they categorized using the NephroCheck with the presence of AKI. And as you can see here, the group that has the NephroCheck with AKI has higher chances and higher mortality than the group with negative NephroCheck and acute kidney injury. And again, the NephroCheck positivity is associated with higher mortality and need for dialysis when you do a multivariate analysis. And it's even higher when you compare with CKD, the SOFA score, the lactate on admission, or the creatinine level on admission. So this data has been already shown in the previous lecture, that is, in patients with refractory shock, is there any impact of the vasopressor in the need of renal replacement therapy in relation with the NephroCheck level? So this is my previous study that was mentioned earlier, so in which we compare two groups of patients, one that was requiring 3 vasopressors, and in the other group requiring 2 vasopressors versus angiotensin 2. As you can see here, the absolute risk reduction for AKI stage 2 or 3 using angiotensin 2 was 37%, and the absolute risk reduction for AKI requiring dialysis using angiotensin 2 was 46%. Interestingly, if we evaluate the level of NephroCheck in these patients that have received angiotensin 2, and we use the cutoff of 2 that has a higher specificity, we see that most of the patients that has progressed to renal replacement therapy has more than 2 nanograms per ml at 72 hours, in comparison with the patients that has required renal replacement therapy in the group of angiotensin 2. So the use of NephroCheck at the level of more than 2, it can predict on 72 hours what patients are going to need renal replacement therapy. So this is the clinical decision algorithm that was published by Dr. Kashani and his group, in which he recommends to risk stratify the patient based on the risk for AKI. So we have low risk, high risk, and very high risk. In those patients that has high risk or very high risk is when it's recommended to use a NephroCheck. When we have a result that is more than 3 and less than 2, the recommendation is to continue with the monitoring, consider the use of non-invasive testing like ultrasound or urine analysis, avoid hyperglycemia, try to adjust nephrotoxic drugs and prevent the use of contrast, consider the measuring of other injury biomarkers, and probably consider the use the furosemide stress test. However, in the other group that has higher level of NephroCheck, more than 2, probably is recommended to put on board the nephrologist, continue avoiding hyperglycemia, continue avoiding the nephrotoxins, continue with adjusting of medication, and to keep this patient in the ICU because are these patients at very high risk to present AKI-related complication or progressing to more severe AKI. So I'm going to talk about the furosemide stress test in this specific population. And this test has been previously validated by Dr. Chawla. And this test predicts the progression of acute kidney injury stage 3 or acute kidney injury recurrent dialysis in patients that already have acute kidney injury stage 1 within 14 days. The dose of furosemide that was recommended was 1 milligram per kilo in those patients that are naive to furosemide, or 1.5 milligrams per kilo actual body weight in those patients that were previously receiving furosemide. So, and the recommendation is to monitor the urine output over the next 2 hours after the dose. So the population that they used to validate the study was population admitted to the ICU. Most of the patient has a GFR more than 30, and all of these patients has an early oliguria AKI. So patient with AKI stage 3 on renal replacement therapy or kidney transplant were excluded from the study. And as you can see here, the test is considered response or no response when you have a urine output more than 200 milliliters after 2 hours. This test has an area under the curve of 0.87 for the prediction of progression to AKI stage 3 or AKI requiring renal replacement therapy. And in another study where they compare these furosemide stress tests to other biomarkers, is very interesting to show that it has a better predictive ability than the NephroCheck of the plasma angle for the progression to AKI stage 3. And using in combination also doesn't provide better prediction. In this other graph, using the furosemide stress test to predict the need for replacement therapy also was significantly better than comparing with the NephroCheck of the plasma angle. And combining 2 biomarkers are no better.
I need you to wrap up in 1 minute.
So this was a trial that was presented by Dr. Toluani, in which they compare the use of furosemide stress tests to predict the need for renal replacement therapy. And as you can see here, using the furosemide stress test, it was associated with 75% chances of progressing to renal replacement therapy compared to just 13%, but it's not associated with improvement in mortality. So the furosemide stress test is a very good predictor for progression to AKI stage 3. It's validated in a small sample of septic and cardiac surgical patients. It has better area under the curve than other urine biomarkers. We need larger studies, and probably it's hard to implement it in septic and stable patients. The role of combining with other with the thiazide to evaluate the whole axis it probably is going to increase the sensitivity, and is not validated yet to predict renal recovery. So in this retrospective study, we evaluated the furosemide stress test in 185 patients that were ICU already on dialysis with this characteristic, and we evaluated renal recovery at 90 days. And we found that using the furosemide stress test to predict renal recovery, it has a very good sensitivity of 96% and very good negative predicted value. And if we combine with the NephroCheck, we can see that those patients that recovers, they normally have NephroCheck levels below 1 or below 2 in comparison with those patients that do not recover, that have persistently elevated NephroCheck level more than 2. So to conclude, so I just want to highlight the importance of nephrology follow-up to improve survival in patients with severe acute kidney injury. Thank you so much.